Hi, everyone. Welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine with experts from around the country. Today, we're coming to you live from the 10th annual Arthrex Team Physician Controversies course in Naples, Florida. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan. The Team Physician Controversies is a 2-day conference where we discuss the treatment and management of elite college and professional athletes. Arthrex brings in experts from around the world for this conference, and we're lucky to have a few of them with us today to discuss the latest and greatest.
So we're joined today by two outstanding guests, both of whom are high-volume ACL surgeons who have focused on why traditional ACL grafts fail and what we can do to lessen that risk for our patients. Dr. Pat Smith is an orthopedic sports medicine surgeon at the new Hospital for Special Surgery, Naples Comprehensive Health Facility. Before making the move to Naples, he was practicing with the Columbia Orthopedic Group and served as the head team physician for the University of Missouri Athletics for over 30 years.
And Dr. Krych is a professor of orthopedic surgery and chair of the Department of Orthopedics at the Mayo Clinic in Rochester, Minnesota. He previously served as the chair of Sports Medicine Division and director of the Orthopedic Surgery Sports Medicine Fellowship. He's also a team physician for the Minnesota Timberwolves. So Dr. Smith and Dr. Krych, thank you so much for joining us today. We're so excited to have you.
Welcome to the show.
Thank you.
Thank you.
So today we're talking about one of our favorite topics, which is ACL surgery. And as I mentioned, we're specifically focusing on reducing the risk of failure after ACL reconstruction. We all know that ACL reconstruction works well, but high failure rates, particularly in young athletes, are still very real. And over the last decade, we've seen a huge evolution in graft choice, biologic augmentation, graft fixation, and mechanical protection. And that's what we're going to discuss today.
So before we get into the details of augmentation and protection options, we're going to just start with foundation. So graft choice. So let's start with you, Pat. So Allograft versus Autograft, how are we making that decision?
Definitely in my practice, Catherine, it's always pretty much Autograft. Maybe in somebody who's 60 or 70, I might use an Allograft, but I just feel like autograft tissue is best for me.
Do you feel similarly?
I think, you're trying to match the right graft to the right patient. And, there's a trade-off with everything that we decide, in ACL surgery. So yes, I think the vast majority of patients, could benefit from autograft, but there are some older patients or patients that maybe want to, trade off getting back to life quicker and sport later that may elect to have an allograft and in the right circumstances can do well.
Yeah, and I think this is where that important conversation you have with patients comes into play. They'll come in requesting an allograft because it's less pain they heard about from one of their friends or one of their friends' parents. But when you explain that failure risk in a 16-year-old soccer player, right, that conversation quickly changes. So now we're going to talk about autograft options. This is people have strong opinions on this. So Aaron, let's start with you. What autograft do you prefer and why? And does it differ based on patient factors?
Yeah, so I think it really should depend on the patient. You're trying to individualize treatment to that athlete that you're seeing in the office, and that can be very different. So I think previously as an ACL surgeon, you had a preference or a choice, but you really should have the entire toolbox available for your athletes and a discussion with them. So some will favor, I want a graft that gives me the lowest failure rate possible. Others are concerned about, donor site morbidity and really to have a nuanced discussion with them. And you hit it on the head. It's shared decision making. And, this is a part of the discussion that they feel they have control of and really do want, some say in it. So again, I don't have necessarily a preference. We take care of a lot of competitive athletes. So, it's been more quad and patellar tendon over hamstring the last 5 or 10 years. But that being said, I think the hamstring autograft can still be a very good graft choice in some patients.
Yeah, Pat, anything to add there?
Yeah, I think similar to Aaron, but I also think that I've been doing this for 40 years, and I think what I've really learned is if you actually, follow your own patients and look at your results, you sometimes are surprised. I was primarily a BTB surgeon for many, many years. And then I did a randomized controlled trial looking at BTB grafts versus hamstring graft. And the number one finding in my patients was I had anterior knee pain in 2 years. This was a very young cohort. The average age when they started the study was 18, so they're 20 years old, stable knees, playing back to sport, but still said, it doesn't feel right. It bothers me. And I did the surgery and, I bone graft the defects. I closed the peritoneum, I take care of the tissues and then my results. So that really was eye-opening for me. And so I, at that point, really kind of switched more to quad. I will use BTB at times, like Aaron says, in certain athletes. I think it probably is a better graft, but I think it's important to tell patients that there are consequences to the graft. Worldwide, hamstrings are still the number one graft, which is a little bit surprising to me because, nobody really emphasizes anymore that the hamstrings are dynamic stabilizers for the ACL. It seems to be forgotten. But the Retear rates, and many, many studies have shown hamstring grafts have a higher failure rate. So I'm primarily quad, but in some BTP.
Yeah, I love that, that talking about our outcomes, and we always have to look back. And I think sometimes you think and not until you dive into the data do you know. And I would also add, talking to our physical therapists, what is the actual patient's experience with the rehab? And I think that anterior knee pain does come up. But in addition to the graft, we also think about, the graft itself as graft fixation. This has evolved over the years. So Pat, I'd love to hear, how you've seen graft fixation evolve over the years in your perspective.
Well, I think it's been a major change with the development of suspensory fixation, right? I think that's really been a game changer. For me, I think the major advantage, especially with a soft tissue graft, but even with BTB, you can use it on the femoral side, you can retension the graft. And I think that's really huge to be able to intraoperatively cycle the knee. It used to be you put a graft in and nobody could touch the knee. You can't do a Lockman, just close and get out of there, right? But, when I started, training fellows, they'd say, can I feel it? I go, yeah, feel it. So, and they can do a Lockman, do a pivot. And, it's important to know, first of all, if it's not perfect and you got a little pivot, glide or whatever, then you may need to do something right away, you LAT or something to back up. But still, the ability to retention, for me, I think is a huge advantage. And I've used it for BTB. And you can retension a BTB graft, especially a young person, if you need to. So I think that ability of retentioning, for me, suspensory fixation has taken over.
Yeah, so you just nicely highlighted how graft fixation has changed, and you're talking about suspensory fixation. Aaron, are you similar? Are you primarily using suspensory fixation, or does it depend on the graft that you're using?
Yeah, I think I agree with Pat in terms of just the readjustability of suspensory fixation has been a game changer. Traditionally, when you had a fixed loop, I think there was a variability in terms of how those postoperative exams felt. The joke would be you'd only let the residents and fellows feel the good ones. But really, I think the fixation being adjustable, readjustable, you take out that millimeter to, of creep before you leave the operating room. And let's be honest, 2 millimeters makes a huge difference in ACL surgery. So that's why we need to be so precise about it. But suspensory fixation has evolved, and it's at a place now where, it's just very consistent and reproducible for our grafts.
Yeah, I think you both mentioned, with suspensory, you're tensioning. So that retensioning aspect of the tightrope is really key, and it allows us to make sure that we're happy with that tension before we leave the operating room. And with everything, there's advancements. So we now have the tightrope SB. So Pat, can you talk to us a little bit about that device and what that's changing for you?
Well, I think, the tightrope and now we've actually got a button that's no longer, going to be seen as a button, right? It's a soft tightrope, which has some huge advantages, obviously for the patient, and especially if you have a multi-ligament case where you have to worry about a bunch of metal buttons. I think the other advantage for me with the new technology with the soft button is it's a little bit easier for me because I internally brace all my ACLs, no matter whether it's BTB, quad or hamstring. It's a little bit easier now on the tibial side to fixate your internal brace. So I think that is a big advantage for me personally, besides the fact that you don't have any metal on your x-ray for the patient. So you can see it because it's got a radiographic marker, but it's not a metal button. And I think, patients, that's important to them. They don't want to have a foreign body in their knee joint left over. So they always ask that, is my knee going to go off in the airport, because you did this graft? And but I think that's a big advantage of the new soft button.
So that's advancements in graft fixation. Now let's talk about advancements in augmentation options, starting with biologics. So we know that ACL grafts fail biologically before they're going to fail mechanically because of structural weakening during that ligamentization process. And the bio-ACL technique has been described as a way to potentially combat this. So Aaron, can you, for our listeners, describe what the bio-ACL technique is and how it may work to lessen this window of vulnerability?
Yeah, so essentially the bio-ACL is trying to solve the problem of, soft tissue to bone healing, and hopefully to prevent, the tunnels widening over time. So can we, improve that timeline? Can we have it quicker? So what it actually does is you take, a bone graft and actually place it in the tunnels with a bone marrow aspirate concentrate. And I would say it's early. I mean, any effort to improve the biology of ACL is absolutely worth pursuing. And I'd say early on, it's clearly been shown that it's safe. It doesn't cause any, adverse effects. In terms of improving outcomes, there's some early time points, maybe 6 weeks and 3 months, looking at some functional gains, but I think it's a little early, to really see 2-year benefits or, decreased graft rate of ruptures and things like that.
Yeah, Erin, I think that's helpful. And as far as the surgical technique itself, for a surgeon who is going to explore the bio-ACL, Pat, is there any pearls that you can give to anyone who wants to try this procedure?
Well, it's, I think that, the utility is that you're really putting a great mixture into the sockets because you're having bone harvested from your reaming, so you have autograft bone. As Erin mentioned, you've got bone marrow concentrate with usually demineralized bone matrix, DBMs added with BMC, or you can use PRP. So it's a pretty powerful mixture. Yeah. I think for me personally, I would more think of it on the tibial side. I think we have more issues with tibial widening than the femoral side. I think the big question biologically, and Erin maybe can chime in, is the question is if you get the graft to heal better in your sockets, does that necessarily translate to the intra-articular portion of the graft healing quicker? Because we know that there are cytokines in the joint and that there's no synovial protection for that ACL graft. And so I think that's really a big question. Does it translate into the graft healing better, which, remains to be seen.
Yeah, I think it's just a higher bar of evidence, if you will, when we're looking at biology versus biomechanics, because we have to prove, 1, that it heals better, and then 2, that better healing translates to improvement of the graft and prevention of failures.
Yeah, so as you're alluding to, we have some literature, primarily MRI studies, showing potentially faster graft maturation, faster integration, but we're still waiting on those larger randomized control trials, as you mentioned. But it seems promising. So let's switch gears now away from biologics, talk about mechanical protection of the graft using that internal brace. So Erin, when did you first start using the internal brace for ACL reconstruction and why?
Yeah, so I'll start with the why, and you alluded to it at the beginning of the program. It's failures in our highest demand athletes, and ACL failure is devastating, for the athlete, but also for the knee as well. We see more chondral damage, more meniscal damage, et cetera. So really there was an interest in improving, the number of failures that we were seeing. So I was an early adopter of internal brace, and, we published some early data just at least showing that it was safe, because there were some, thoughts kind of hanging over from previous, quote unquote synthetic grafts with ACLs that, was there a risk of synovitis and inflammation, all these other things. So that was the initial efforts, was just to make sure it was safe, and it certainly was. And then really Pat, has had the definitive data with all of his great trials looking at, the improvement in failure rates.
Can you speak a little bit about that?
I'd love to hear that.
Yeah, it's been a long journey. I just had this idea, it first started the ankle was described by Dr. Gordon Mackay out of Scotland to internally brace the rostrum, right, which took hold. Now, obviously, that's extra-articular. So I thought, what about intra-articular? Like Erin, I personally would like to be an ACL surgeon who never had a graft failure. Revisions never do as well, no matter how good Erin is, his revision will not do as well as his primary that lasts, right? That's for anybody. So that was my goal, and so I thought, what if we did it in the joint? So immediately there were a lot of red flags as foreign body. So I happened to be, when I was at the University of Missouri, I was affiliated with the medical school and the vet school there, so I was able to do some canine studies, and the canine is a really good translational model, and we showed that it was safe in a dog knee to put the tape in, number one, even if the tape was ruptured. And then the question was, how is it going to work biomechanically? So then we did some testing with Arthrex and really showed that it's protective at high loads. It doesn't stress shield the graft, but it just protects the graft at a high load, which is really ideal what you want. You want the graft to see load to revascularize and remodel, but for a high load, that's when the tape kicks in to protect. That's protected. That's what's shown biomechanically. So then I started doing it clinically, and again, data is important. And, I don't know about Erin, but when patients would ask me, Doc, what's the chance my graft could fail? I used to say like 3%. I don't know. I thought it was pretty good. So, but I had a research assistant who collected all my data with the internal brace, our initial data. We published my first 100 cases without internal brace, 100 after. They were all autografts, primarily BTB initially, and then more quad later. But my Retear rate without internal brace was 8%, you know, which I was going to count. So not very good. 8% was higher than I thought. And it was 1% with internal brace. So that really was kind of, for me, I said, you know, I got to do what's right for my patient. So, but again, I got a lot of pushback. This artificial ligament, you know, it's bad for the joint, especially in Europe. It's synthetic. You know, people are kind of all over me. But, you know, I put in Gore-Tex in my fellowship back in 1985, and Gore-Tex was a disaster. So I've lived it. So I would never want to put something in a patient of mine that could have those risks. And I felt really comfortable that it was safe to do. So I've done it in every ACL that I've done since 2016, except for 2 patients who I didn't do an internal brace on their side. They want me to do the exact same thing. That's it. I put it in everybody, whether it's a BTB, quad, or hamstring. And we published our data here recently. You know, quad and BTB have been fantastic with internal brace. My hamstrings did not do as well. You know, I'm an honest guy. I present the data. My hamstring failure rate without internal brace was 12% at 2 years. It was 2.5% with internal brace. Pretty good, not bad. 12% a young group. These are all young patients. We followed them at 4 year. I had published a 24% failure rate in my hamstrings at 4 years in athletic population. That was a tough one to swallow, but it's true. But my internal brace was only 5%. So if you do a hamstring, for sure, I think you need to at least do an internal brace. But for me, it's been just, I think, game changing. It's just really nice not, you know, having to do a lot of revisions. You know, I mean, I get them from other places, but, you know, when mom calls and says, you know, Johnny hurt the knee, you're always hoping, gosh, I hope it was the other side. I hope it wasn't the one that I did, right? It's terrible, you know, and ACL injuries are devastating. You know, nobody's not shown that you're not going to get later osteoarthritis, especially in revision, as Aaron pointed out. It's just not as good. Condyle damage, meniscal damage. So for me, the primary reason I do it is not for patients to run faster, jump higher, come back quicker. No, it's just I don't want them to re-tear.
Yeah, absolutely. And, you know, as you said, we're trying to protect and not restrict. You want the internal brace to engage at higher loads, but it's certainly not supposed to restrict the knee. So we don't want to over-tension. That's something we want to avoid. So Aaron, what would you suggest to people as far as pearls or pitfalls in the OR to avoid that?
Yeah, so I think, you know, again, we have to follow the data, and Pat has taught us a lot, and I thank him for everything that he's done. But, you know, when you look at the biomechanics of it, it's important that, you know, the graft doesn't see any stress shielding. So you want to make sure that you're tensioning your internal brace first and then your graft second. So you really want your final loads to be, you know, on the graft itself. So that's something Pat taught me. And I used to do it the other way around, but again, it's important to do internal brace first, graft second. Again, you want to do it in full extension. We talked about the evolution of suspensory fixation before, and with these grafts now, they're very, very stiff. So if you're used to tensioning them back at 20 degrees with BTBs and things, you don't want to do that with the current internal brace and suspensory fixation, because you'll constrain, and patients will have a hard time getting their extension back.
Any other pearls or pitfalls to add in terms of lessening risk of stiffness with the addition of internal brace? That's a concern we hear about a lot.
You know, I think Aaron hit the nail on the head, really. And I think it's also understanding the normal biomechanics of the ACL. We know that the ACL loosens by about 3 millimeters from 0 to 9 degrees of flexion. So if you fix them full extension, and always in every case that I've ever done, you can see at 90 degrees, the tapes are loose. That's what you want. Nobody's really tearing their ACL at 90 degrees, right? They're tearing it toward extension. But Aaron's absolutely right. If you fix it at 20 degrees, you may have a problem. So I always go even hyperextension. So if a patient has 5, 10 degrees of hyperextension, that's where I fix the internal brace.
Great.
Yeah. So as far as the data behind the internal brace, you've already spoken a little bit about your own data as far as the outcomes. But, you know, from you both, how are you noticing that the internal brace impacts clinical outcomes after ACL reconstruction?
Yeah, I think, you know, taking a pragmatic approach, it really, you know, again, the most devastating consequence of the surgery is a failure of the graft. Because that, again, is just a terrible event for the knee in terms of its overall health. And obviously for our athletes, you know, to be out again with another, you know, ligament injury is absolutely devastating for them. So I think that should be at the top of the list whenever you look at ACL outcomes to prevent graft rupture. And, you know, Pat quoted the data. It clearly reduces that. So again, very compelling. And when you start with that, it's hard to go any farther because it really does work and works well.
That's great. So now let's finish up, we talked about mechanical protection and biologic protection. Let's talk about extra-articular protection with the lateral extra-articular tenodesis. So, Pat, why should surgeons consider adding a lateral augmentation procedure to an ACL reconstruction? How does it impact ACL outcomes?
Well, I think there's, in my mind, it's important. It's just a question of what patients need it. Personally, I've had, and everything I've published on the internal brace augmentation is without LET. So I think, do you need both? In my practice, I do an extra-articular procedure about 20% of the time. Typically, it's in somebody that has more than 7-8 degrees of hyperextension on their normal side. As Aaron and his group showed, the highest risk of retears is our female soccer players under the age of 20. So I will do an extra-articular in all those patients in a high pivoting sport. But for me, it's about 20% of the time because I've had such good success with internal brace augmentation. And, the issue is, it's another procedure. There are risks to doing it. There's, costs of implants. I mean, there can be problems if it's not put in the right place. So I think it's in our armamentarium, certainly. And the data shows whether you do an anterolateral ligament reconstruction or a modified lamella, which is typically what we're doing with the LET, they're both equivalent in terms of decreasing your retear rates. But, the spectrum is, large. I mean, Bertrand Sonnier-Cote does it in 98% of his ACL patients. But when you really look at what they do in Lyon is, they're using one graft, one hamstring. So they're trying to recreate not just the ACL, but the LET with the gracilis hamstring construct. So it's kind of one long loop graft. That's what I was just in South America, Brazil, with the ACL study group. And that's what they're doing down in Brazil with the rectus femoris graft now, one long graft to recreate, not just the ACL, but, the ALL or the LET. So that's a different feel for me that they're doing it in every case. But certainly if you're doing a hamstring graft, I'm glad they're doing LET, ALL because the failure rates are so high. But I personally do it about 20% of the time. And I think it's patient, decision-making is based on their sport and their, Baton criteria, hyperextension are the things I really look at.
Yeah, I think, Aaron, I'd love to hear if you have anything to add as far as your indications, but then also we'd love to dive into technique as far as what do you do to fix the LET and how has that evolved over time?
Yeah, great question. So I think Pat hit it really well in terms of indications. Everything is a trade-off. There's no free lunch, so to speak. So, you're really trying to target those highest risk patients that benefit the most. If the benefit's negligible, then all of a sudden the trade-offs maybe aren't in your favor. And then, they can have, sometimes some lateral pain and other things out there. In terms of technique, the technique has gotten so much better, than it was 5 and 10 years ago. So things that we used to worry about, and I'm more of a modified lamella than an ALL reconstruction. But we used to have trouble with collision, a lot of collision between the ACL, femoral socket, and the LET. Now with suture anchors instead of tunnels, so-called on-lay fixation, that problem has become much, much better and fortunately is pretty uncommon. So I think just familiarity with anatomy, doing it with increased frequency, having a suture anchor for fixation, I think really has facilitated making this a much easier procedure that really, we aren't seeing too many adverse events or any outcomes in our patients. So
Absolutely.
So that knotless fiber tack for LET was a real advancement. You can tie, you could do a suture staple, you could do a hybrid, and not only, as you said, decreases the risk of ACL tunnel convergence, but also less bone removal as well. But we still have to be paying attention to where we're placing this. As you alluded to, if it's placed wrong, that could be a problem. So Pat, any pearls or pitfalls in terms of placing it in the correct location, angle of the knee when you're tensioning it, and how much tension you're placing on the IT band graft?
Yeah, good question. So I think it's really important that you are proximal and posterior to the lateral condyle. That's either fixation for an Allograft or if you're going to do a modified LET, the modified lamella. Personally for me, I typically fixate the graft at 30 degrees of flexion with neutral rotation. And I make sure that the knee has full extension. The lamella tends to be more isometric. You got to make sure I also flex the knee. You want to make sure you have your full flexion. The other thing I think that's important is protecting the native anatomy, as Aaron alluded to. And that for me is the deep IT band, so-called Kaplan fibers and what we call the capsule osseous fibers. So for me, I grew up in an era that's really be foreign to everyone at this table. But when I first started my fellowship, my first 3 years in practice, I did not do an intra-articular ACL reconstruction. I did all extra-articular procedure. So I grew up on that lateral side of the knee, and that's what we did. We basically fixated the IT band to the lateral muscular septum and tightened the capsule osseous fibers. And interestingly, it worked in a lot of patients to eliminate the pivot shift. They still would have a Logan, still would have an anterior drawer. So it's kind of back to the future for me. So, but I think preserving those deep fibers when you do the exposure, you just can't cut through those, and because they're an important secondary stabilizer. So actually what I do, I love the double knotless fiber tack soft anchor for all the reasons Aaron mentioned and you mentioned. What I also do is I take the 2 sutures after you complete the tightening of the loops on the graft. I actually take those 2 sutures and pass them through the deep fibers of the IT band and retention them right there with those 2 sutures to give another point of restoration of that anatomy. Because we know when you tear your ACL, you do something on the lateral side. Either, your lateral capsular ligament or the ALL is injured or the deep IT band fibers are injured. That's been shown in studies where you look at, immediate ACL making a lateral incision, you see that injury. So it's a complex. It's not just intra-articular. There is injury to the lateral side that happens.
Yeah, so it's very helpful. And as we've alluded to, we worry a lot about ACL failures. It's what we don't want to hear. We don't want that phone call to come our way. And so the thing we'd like to end with from both of you is really from the time the patient enters and you diagnose them all the way to you're allowing them to return to play. Like, what is your checklist of things that you do, whether it's intraoperatively, intra-articularly, or extra-articularly, biologically, that you do to reduce their risk of failure? So, Aaron, I'll put you on the hot seat first.
Yeah, it's, it really is end to end. You described it as a journey, and I think that's an apt description because we discussed earlier, it's a couple millimeters makes the difference for this athlete, which is, I would say, very humbling. So really everything has to be perfect. From the preoperative discussion, having them buy in, understanding, the journey ahead. Everything in surgery that we talked about. We didn't touch base on, tunnel and socket placement, which we still see could be the, highest risk for failure. So that's on us as surgeons to, be consistent every single time and bring our A+ game, to surgery for our athletes. And then just, being there for the journey. And you mentioned the importance of our physical therapists. Unbelievable how great they are and really, taking on the patients with us and following them over time. So I think just it's a team approach. Everything has to be perfect. And, fortunately, if we do our job well and the patients and athletes are motivated, you can have a great outcome and get back to what they want to do.
I would add, everything Aaron, I'd agree with 100%. I think that thing that I really focus the most on really is postoperative, and it's their extension. I think it's critical that your patients have absolute full knee extension. So, not just fixing the graft and extension. I move my patients right away and really talk to them, day 2, 3, put your bump under your heel. You have to have extension, and especially that's an issue with quad grafts, which have become so popular.
Yes.
But it's really, it's a blow to the extension mechanism. And I think probably, and Eric can chime in too, but probably even more so than a patellar tendon, I think. So, and since I do a lot of quad grafts, I've really been sensitive to that and the risk of scarring or arthrofibrosis. So for me, because if an athlete doesn't have their full extension, they never get their quad all the way back, and they're never going to be the same. So I think really being aggressive with extension, as Aaron does, I communicate with my physical therapist. I talk to them. There's a problem in the clinic. I get them on the phone when the patient's there. We need to work on this. And if they don't have it, then I may go in arthroscopically and get it for them. But if they don't have full extension, 2 things. 1, they won't be the same athlete. 2, I believe that part of our problem with late OA is that patients don't have full extension. We never talk about what's called the screw home mechanism, where the lateral femoral condyle rotates an extension. And if you don't have full extension, you don't get there. So then the kinematics of the knee have not been restored. So I think that's part of the problem. Yeah, they're stable. When they don't have full extension, they don't pivot. So they can go out and play a few years and probably be somewhat successful. But when they're 40, now they're starting to get medial OA, medial compartment changes, and it's just not the same knee. So for me, I think the rehab is extremely important. And I think the physician, the knee surgeon, has to be involved actively, not just write a prescription and say, you'll see in 6 weeks. When you get the report from the therapist says they lack 5 degrees of full extension, you better call that patient and check them yourself and do a splint or something to get them going. But you got to get full extension is what I think really is critical for me.
Yeah.
Catherine and I discuss that all the time, how it's
Yeah.
really critical to find a skilled PT to be taking care of your ACLs after surgery, because 1 or 2 degrees extension loss, that, as you put it perfectly, they're never the same. So we
Agreed.
always try to emphasize that.
So this is really great discussion. I think, we hit a lot of points as far as, talking about grafts and graft selection, how important that is, all the way to, how are we dealing with things intraoperatively? Can we add things like the internal brace or LET to further stabilize the knee? But also all the attention to detail with rehab is equally important.
Thank you so much for joining us today.
Great.
We really appreciate your time.
Thanks for having us.
Thank you.
And thank you for listening to this episode of the Sports Docs Podcast, live from the Arthrex Team Physician Controversy Conference. We hope you enjoyed our discussion today as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine.